Professor Madhi, for agreeing to give this talk. I think we've had a lot of interest on this talk, and also thank you for accommodating us, because we normally have these seminars towards the end of the month or the last week of the month, but and you're able to do it now. Thank you. Just to give you a brief bio of Professor Madhi, he's currently the Dean of Faculty of Health Sciences at Witwatersrand, and he's a professor of vaccinology. He's also a co-director of the African Leadership Initiative for Vaccinology Expertise, or ALIVE. He completed his undergraduate and postgrad in Witwatersrand, and qualifying as a pediatrician in 1996 and a PhD in 2003. He also holds other positions as a director of the South African Medical Research Council Vaccines and Infectious Disease Analytical Research Unit, or called VIDA, and he's also a research chair in vaccine preventable diseases at DSI, and he currently also serves as the chair of the National Advisory Group on Immunization in South Africa, and also is a member of the huge strategic advisory group of experts of immunization, or called SAIS, and he's been doing that since 2019. He has published over 460 scientific publications since 1997, so it's extremely impressive. His research has mainly focused on epidemiology and clinical development of life-saving vaccines against pneumonia and diarrhea, which we know that probably one of the biggest killers, particularly in children. And also over the past decade, he has focused more on vaccines that are being developed for immunizing pregnant women, which has shown to have some benefit, particularly to women and also their young infants. And he led the first 2 clinical trials on COVID-19 vaccines, which were undertaken in Africa, or specifically in South Africa. So over to you, Professor Madhi. Thank you.
Really provide some reflection on where we are with COVID-19 in South Africa. And in doing so, obviously an important starting point is first to reflect on what has transpired, and not just in South Africa, but as well as in Africa, because it has got implications as to how we move forward in the region when it comes to responding to COVID-19. And then I'm going to briefly touch on COVID-19 vaccines and the South African experience, and what had worked and what probably we could have done better. And then wrap up the talk on some recent data, which really reflects on where we are with the pandemic and experiences in particular during the course of the 2 most recent resurgences due to Omicron BA1 and BA4, BA5. So globally, the number of cases of COVID-19 that had been documented as of the 13th of June 2022 was in the region of about 540 million. But importantly, of those 540 million, only 9.2 million cases were documented on the African continent, which is less than 2% of the total number of cases. This despite Africa constituting 18% of the global population. When we unpack that a bit further, of those 9.2 million cases recorded in Africa, almost 4 million of those cases, 45%, were recorded in South Africa, which makes up less than 5% of the African population. So obviously, there seems to be a disconnect in relation to the number of documented cases of COVID-19 in Africa, as well as the proportional representation of South Africa to the contribution of COVID-19 cases on the continent. Now, as you can see on the right-hand side, what we basically find in Africa is that in many parts of Africa, in fact, the incidence per 100 million cases, and this is of confirmed COVID-19, is less than 100 per million of the population. South Africa, Botswana are amongst the countries with the highest incidence. But even then, the incidence in a country such as South Africa is substantially lower than the incidence per million of the population compared to North America, compared to many European countries. Now, very much underpinning this, and one of the major reasons, is real heterogeneity when it comes to the amount of COVID-19 testing which has been done. So South Africa, Botswana probably does amongst the highest rate of testing on the entire continent. South Africa does about 20 times more testing than Nigeria, as an example. But at the same time, the amount of testing that's done in South Africa per capita, per thousand of the population, is about 15 to 18 times lower than the amount of testing that's done in the United Kingdom and as much as 7 times lower than the amount of testing that's done in the United States. So what this data really reflects is that it's almost impossible to make any sort of head-to-head comparisons between different countries, and sometimes even within a country, as to the burden of COVID-19 because of this huge heterogeneity when it comes to the amount of testing, consequently a variability when it comes to the number of cases that are being documented. Now, illustrating this is data from sero surveys, and this is data from sero surveys that were done up until middle of November 2021, prior to the onset of the Omicron wave. And what basically this demonstrates is that, as opposed to what was suggested as being a very low burden of COVID-19 on the African continent, the continent with the highest seropositivity as a measure of past infection before the onset of the Omicron wave was, in fact, sub-Saharan Africa, with the average seropositivity rate of 79%. As opposed to the 550 million cases of recorded COVID-19, the number of people that have been infected before the onset of the Omicron wave was more in the region of about 3.4 billion. So more than almost half of the world's population had been infected at least once before the onset of the Omicron wave. And the region with the highest number of cases, unsurprisingly, because of the large population as well as a high force of infection, was South Asia. Now, in addition to the recorded number of cases, what also matters and probably matters more is the number of people that have likely died of COVID-19. Again, as of the 14th of June of this month, or 14th of June of 2022, the total number of individuals that were recorded to have died of COVID-19 was in the region of 6.3 million, of which 255,000 were documented on the African continent. Once again, South Africa, which makes up less than 5% of the African population, accounted for almost 45% of all of the documented COVID-19 cases. Based on modeling using the sero survey data as well as infection fatality risk, the estimate around about the middle of November 2021 is that there was already significant under-ascertainment of the number of people that had likely died of COVID-19. Rather than being at 6.3 million, the number of people that had probably succumbed was closer to the region of about 15 million, with an uncertainty bound of 11 to 20 million. Instead of low and middle income countries and low income countries being spared from COVID-19, all indications are that especially low middle income countries have had substantially higher mortality rates per 100,000 of the population compared to high income countries. South Africa is an upper middle income country, but as I'll show you in the next slide, the estimate in terms of mortality using excess mortality data is very similar to what is observed in other low middle income countries, where the mortality rate per 100,000 as of the middle of November 2021 was already exceeding 300 per 100,000, compared to in the region of about 200 per 100,000 for high income countries, upper middle income countries, and low income countries. So again, what we see is a huge differential difference between the modeled number of deaths from COVID-19 before the onset of the Omicron wave, as opposed to the recorded number of COVID-19 deaths globally. Now, one of the major reasons for this, obviously, is, as I alluded to, where there is such huge amount of heterogeneity in testing, where there's heterogeneity in access to healthcare facilities, heterogeneity in terms of the robustness of record keeping as well as of reporting of cases, you get the sort of variability that arises. Now, what has recently taken place is that this is an analysis which uses the United Kingdom as a benchmark, as a reference standard. Because in the United Kingdom, the number of recorded COVID-19 cases very much almost aligns with the excess mortality that is attributable to COVID-19 deaths. So using that as a reference point, what we find is that some countries such as India and Egypt, the number of recorded deaths probably underestimates the number of people that had died of COVID-19 by 10 to 12-fold. In South Africa, what we find is that the difference between the recorded death and the actual excess mortality COVID-19 attributable death is about a 2.6-fold difference. What we see globally per 100,000 of the population when it comes to using excess mortality as a measure of the number of COVID-19 deaths, and this is excess mortality due to all causes, not only from natural infection, we find that excess mortality globally, the COVID-19 death rate has probably been in the region of about 250 per 100,000. In South Africa, we're sitting close on to 400 per 100,000, similar to what it is in India, but substantially higher than the United Kingdom. In fact, using excess mortality estimates, the mortality rate from COVID-19 in South Africa has been 2 times higher than what it is in the United Kingdom, which was sitting at about 200 per 100,000. Now, that itself probably paints a relatively optimistic picture as to the number of people that actually died, because when this analysis is redone, looking at excess mortality from non-accidental causes, and there was substantial reduction in accidental deaths during the course of the COVID-19 pandemic because of a number of restrictions and regulations that have been put into place. The excess mortality attributable to COVID-19 mortality using the excess death modeling is in the region of 530 per 100,000 in South Africa. In some regions, in some provinces, such as the Northern Cape, sitting at 740 per 100,000, in the Eastern Cape, 670 per 100,000. Now, this high rate of excess mortality would put South Africa amongst the top 5 countries with the highest COVID-19 mortality rate globally. An excess mortality of 534 per 100,000 puts South Africa firmly amongst the top 5 countries with the highest COVID-19 mortality rate globally. So could some of this have been avoided? And the short answer is yes, some of it could have been avoided. But unfortunately, there were a number of missteps that transpired in South Africa, and particularly when it came to the tools being available to us to protect against what mattered most, and that is protecting against severe disease. And now I just want to reflect briefly on COVID-19 vaccines and its rollout in South Africa, and then follow it on as to where we are with COVID-19 vaccines and what should happen next. So I think all of us recall the great fanfare which greeted the arrival of the AstraZeneca vaccine, COVID-19 vaccine on the 1st of February 2021. And the procurement of this vaccine was probably done in record time. What happened early in January of 2021, when there was clearly evident that government had made little effort in terms of procuring vaccine other than depending on a COVAX facility, almost overnight, there seemed to have been some arrangement between South Africa and the Serum Institute of India in India to basically at least provide South Africa between 1 to 1.5 million doses of the AstraZeneca COVID-19 vaccines. So these vaccines arrived on the 1st of February 2021, and the timing of its arrival was pretty much at a time when the Beta variant was very much peaking in South Africa. So as we all know, the Beta variant evolved around about September of 2020, gained traction in November 2020, and then we had a massive surge of cases, very much peaking, and in fact on a downward trajectory by February at a time when the AstraZeneca vaccine arrived. Unfortunately for South Africa, at a time just the day before the arrival of the AstraZeneca vaccine, we were finalizing some analysis of a study that we had performed on AstraZeneca vaccine, which was a study that started enrolling participants already around about July of 2020. And it is only after this resurgence that we accrued sufficient number of endpoint cases to do a meaningful analysis of the effectiveness of the AstraZeneca vaccine. Now, what was shown in this particular study, which basically then spoke to the efficacy of the AstraZeneca vaccine, at least against mild to moderate COVID-19, is that although the AstraZeneca vaccine induced good antibody responses, including neutralizing antibody responses against the ancestry virus, the Wuhan strain of virus, when it came to the Beta variant, the neutralizing antibody activity induced by the AstraZeneca vaccine had very little activity against the Beta variant. More than 80% of participants that received the AstraZeneca vaccine demonstrated no neutralizing antibody activity against the Beta variant. Now, what was already appreciated at that point in time from some other studies that had been conducted in the Northern Hemisphere is that there was a strong association, a strong correlation between the magnitude of neutralizing antibody induced by vaccines and the efficacy of those vaccines against the wild-type virus as well as against the Alpha variant. So when we saw that there wasn't much neutralizing antibody activity against the Beta variant, and we knew that the majority of the endpoint cases that were being accrued in the study were due to the Beta variant, it came as little surprise that we didn't show any protection of the AstraZeneca vaccine against mild to moderate COVID-19 due to the Beta variant. And I'm emphasizing the point that this was mild to moderate COVID-19. This was a phase 1, phase 2 study. We were risk averse. We didn't enroll individuals that were at high risk of developing severe disease because we were still at an early stage of the clinical development of this vaccine. We targeted individuals that would mainly at best get mild to moderate COVID-19, and that is exactly what transpired. So the summary of this is that efficacy of the AstraZeneca vaccine against the Beta variant was basically non-significant, no protection due to mild to moderate COVID-19. However, at the same time, what we also reported in the same study was that despite there being very little neutralizing antibody activity induced by the AstraZeneca vaccine against the Beta variant, when we looked at the T cell responses, both the CD4 as well as the CD8 responses induced by the AstraZeneca vaccine, the majority of those T cell responses were relatively conserved, even despite the mutations present in the Beta variant. So of the 87 epitopes that we targeted in terms of T cell responses, 76 of those responses were largely conserved with the AstraZeneca vaccine. Now, this basically resulted in us making a case that despite the vaccine not protecting against mild to moderate COVID-19, just using first principles, not of SARS-CoV-2, but first principles of immunology and the manner in which the body responds to viruses, the role of antibody in terms of preventing infection, the role of cell-mediated immunity in preventing progression of infection to severe disease. Using those very basic first principles of virology and immunology, we still indicated that there was still a place for the use of the AstraZeneca vaccine. And when I say we, it was a few people in South Africa. But in addition to a few people in South Africa, the scientific advisory group of experts at the WHO also came out almost immediately after we released the results from South Africa. And they recommended that even in countries where the Beta variant was circulating, those countries should still continue using the AstraZeneca vaccine because there was indirect evidence which was compatible that the vaccine would protect against severe COVID-19. Many people in South Africa basically dismissed this recommendation from the WHO, and instead the narrative at that stage was we should rather wait for another vaccine which we know that would work against COVID-19, including the Beta variant, and in the meantime, rather than vaccinating high-risk individuals with a vaccine that probably would protect them against severe disease, simply leave them unprotected. And that came with consequences. Now, the consequences of that was basically South Africa then made a decision to sell off the AstraZeneca vaccine. It ended up being procured by the African Union, which basically then deployed it to other African countries where the Beta variant was also circulating. But these 1.5 million doses essentially were lost to South Africa, were lost to being utilized to immunize high-risk individuals. And what subsequently transpired is that by the time we started to introduce COVID-19 vaccines at a general population level, which was only around about June 2022, the Beta variant had very much subsided and had been completely replaced by the Delta variant. So in addition to had we used the AstraZeneca vaccine in February of 2021, as I'll show you, it probably still would have conferred protection against severe disease due to the Beta variant. More importantly, we left the population completely unprotected. And by the time we started to use the Pfizer vaccine, which became available, we were already in the midst of a major surge of cases of COVID-19 as well as deaths of COVID-19 during the course of the third wave, which was due to the Delta variant. And as I'll show you, the Delta variant, as you can already sort of see from this particular graph, contributed to the majority of cases of COVID-19 as well as deaths from COVID-19 since the start of the pandemic. Now, as I mentioned, the AstraZeneca vaccine subsequently in the study from Canada was actually shown to reduce hospitalization and death either from the Beta or the Gamma variant in the region of 80%. So there was 80% vaccine effectiveness of the AstraZeneca vaccine against the Beta variant, despite the vaccine not inducing neutralizing antibody activity against the Beta variant. And all of this, obviously, now that we've come to understand it better since then, but which was already evident from experience with other vaccines and other viruses, was largely being mediated because of the T cell immunity having remained relatively conserved. even that T-cell immunity, immune responses induced by the AstraZeneca vaccine, despite the mutations that were evident in the spike protein. In addition to that, what the AstraZeneca vaccine was also subsequently shown to do, and this is just one study from Canada with a number of other studies from elsewhere, is that the effectiveness of the AstraZeneca vaccine against the Delta variant was in a region of 80 to 85% when it comes to protection against hospitalization and death. Where do we stand with COVID-19 in South Africa when it comes to vaccination? Right now, we're almost 1 year into the vaccine program. The Department of Health has set the target of vaccinating 70% of the population by the end of 2021, and clearly we missed that target. We're now reaching close to a goal of using 40 million doses of vaccine. But at the end of the day, the number of people that have received at least a single dose of vaccine in South Africa is only about 1/3 of the population, way short of the 70% target of the population, which we were aspiring to reach by the end of 2021. And to some extent, that 70% target now becomes almost meaningless, as I'll show you, because what has emerged in South Africa subsequently is extensive immunity, immunity which has largely arisen at huge cost because of infection, repeat infections in many instances since the start of the pandemic. So globally, there's been more than 12 billion COVID-19 vaccines that have been administered. 2/3 of the world population have received at least a single dose. But in low-income countries, very little traction in terms of getting vaccines rolled out, less than 20% of the population, and as I mentioned, 36% in South Africa. Whether low-income countries and even South Africa should continue aspiring to a target of 70% coverage is highly questionable in the context of the current generation of COVID-19 vaccines and in the context of extensive infection-induced immunity. As I mentioned earlier, by middle of November 2021 on the African continent, 79% of individuals had been infected at least once with COVID-19. Now, things have moved on since then, and what we subsequently experienced after the Delta variant was the emergence of Omicron variant, and that was obviously reported first in Southern Africa around about the middle, towards the end of November 2021, and more recently, we've had a resurgence due to the BA4 and BA5 sublineages. And now I'm just going to really reflect on what the experience has been in the context of those, as well as underlying population immunity. So when the Omicron variant evolved, there was a huge amount of concern that this was a variant that manifested multiple mutations, which suggested that it would be highly evasive to neutralizing antibody activity. And certainly the initial studies, both from South Africa as well as elsewhere, pretty much demonstrated that irrespective of whether individuals received a messenger RNA vaccine, the AstraZeneca vaccine as an example, after 2 doses of the vaccine, very few vaccinated individuals had any neutralizing antibody activity against the Omicron variant, as opposed to the magnitude of neutralizing antibody responses to the wild-type virus, as well as other variants of concern. And similarly, for individuals that had recovered from past infection due to the Alpha variant, Beta variant, or Delta variant, the neutralizing antibody activity induced by those past infections with those variants didn't demonstrate much activity against the Omicron variant. But perhaps different from that was an experience when it came to individuals that had had a combination of the AstraZeneca and the messenger RNA vaccines, what we refer to as a heterologous approach, in that individuals that had this heterologous vaccine schedule, they seem to have magnitudes of antibody responses whereby the neutralizing antibody activity against Omicron, although not absolute, was still relatively well conserved as opposed to individuals that receive homologous schedules of COVID-19 vaccines. In addition to which, what they also showed in this particular study is that individuals that had been vaccinated before or after having been infected, so this is the hybrid immunity, those individuals again had high magnitudes of neutralizing antibody activity, and in fact sufficient so to actually overcome some of the reduced susceptibility of the Omicron variant against that neutralizing antibody activities. So individuals with heterologous schedules and individuals with hybrid immunity, they still appear to have some preservation of neutralizing antibody activity against Omicron, as opposed to individuals with a homologous vaccine schedule or that were infected with one of the earlier variants of concern. And the reason I'm emphasizing this is South Africa is very much in a space now where even with vaccines, it's no longer about whether vaccines work, it's about how well hybrid immunity works. Because the majority of the population, as I'll show you, including the vaccinated population, have been infected with SARS-CoV-2 at least once since the start of the pandemic, and after Omicron, probably a few additional times. Now, the stability of underlying infection, preceding infection prior to vaccination, being able to induce antibody activity that is of a greater magnitude and able to overcome some of the evasiveness of the different variants of concern is also illustrated for AstraZeneca vaccine. These are some unpublished data. And what basically it's showing is individuals that were seropositive at a time when they received the first dose of AstraZeneca vaccine compared to individuals that were seronegative at a time when they received the first dose of AstraZeneca vaccine. And what the data shows is, and I'm just going to focus on Omicron as an example, is that individuals that have been previously primed with infection, they have a robust antibody response, including neutralizing antibody activity against Omicron after a single dose, and in fact, very little gain in addition with a second dose of vaccine in those individuals. Compared with individuals that were not primed with infection, that received an AstraZeneca vaccine, even after 2 doses of vaccine, as shown by the green bar, they've got no neutralizing antibody activity against the Omicron variant, and similarly so for many of the other variants. So priming with infection, and inadvertently, that's where we're ending up in South Africa, where the majority of individuals that are being vaccinated are individuals with infection, is largely contributing to a very different dynamic of difference in terms of kinetics of neutralizing antibody activity being induced. Now, what was also shown, and these again studies from South Africa, is that whilst Omicron was relatively antibody evasive, similar to what we had shown for the Beta variant, is that the CD8 responses as well as the CD4 responses induced by the Johnson & Johnson vaccine, induced by the Pfizer vaccine, as well as induced by past infection, remained relatively intact. So despite Omicron being antibody evasive, we still had relatively intact CD4 as well as CD8 responses. And as I mentioned, given the first principles of immunology and virology, these are really important in the context of preventing progression of infection to severe disease, including due to by variants of concerns. Now, another important study, again, is the same study, which basically also looked at CD4 and CD8 responses, the polyepitopic responses, not just to the S protein, but also responses that are induced by past infection due to the wild-type virus or one of the earlier variants of concern in relation to epitopes of the N and the M protein. And the summary of this essentially is that past infection with any of the variants of concern, including the wild-type virus, results in a broad repertoire of both CD4 as well as CD8 responses, and those responses, because of being induced by infection, are not just only targeted against the S protein, which is what is induced when using vaccines, but also targeted against the N, epitopes of the N and the M protein. And there is some emerging data which shows that even CD8 responses to the N protein play an important role in preventing progression of infection to severe disease. So what do we know about infections? Do they actually work? Do they actually protect against infection? Do they protect against severe disease? And how do they compare to protection in people that have only developed immunity from vaccination? And this is a study from Qatar, which basically looks at the effectiveness of past infection compared with 2 individuals that have received 2 doses of the messenger RNA vaccine. And what the data surprisingly shows is that individuals that have recovered from past infection, in fact, they had a lower risk of developing symptomatic COVID-19 due to Omicron, as well as a lower risk of dying of COVID-19 or having severe COVID-19 compared to individuals that have received 2 doses of the messenger RNA vaccine. So this is comparing past infection with the wild-type virus with earlier variants of concern in relation to effectiveness against symptomatic COVID-19 as well as severe or fatal COVID-19. And individuals that had recovered from past infection actually had heightened protection compared with individuals that only developed immunity from 2 doses of either the Pfizer vaccine or the Moderna vaccine. Does that mean we no longer need to vaccinate? And the short answer to that is no. because at the same time, as I mentioned, the type of immunity that you get from hybrid immunity probably is certainly superior compared with the type of immunity that you develop from vaccine-only induced immunity, but also probably better than only past infection-induced immunity. And this is another study from Qatar, which basically now analyzes the effectiveness of different immune-induced responses prior infection of its own, compared to people that have already received 2 doses of vaccine, 2 doses plus hybrid, plus past infection, 3 doses of vaccine, and 3 doses in prior infection. And what they basically show is that for symptomatic COVID-19, individuals with past infection that received 3 doses of vaccine have got the highest vaccine effectiveness, sitting at 75%, compared to individuals that didn't have any past infection but only 2 doses of the messenger RNA vaccine, which didn't actually protect against symptomatic infection due to Omicron, which pretty much was also the experience in South Africa. But then on the other hand, irrespective of whether immunity was induced from past infection alone, 2 doses of messenger RNA vaccine, or hybrid immunity, protection due to hospitalization and death due to Omicron BA.1 was consistently high across all the different sort of scenarios that induced immunity. And a very similar sort of experience for a BA.2 sublineage. Basically, those individuals with hybrid immunity, and in particular with 3 doses of vaccine, had the highest vaccine effectiveness against symptomatic COVID-19. And effectiveness, although the confidence intervals here are much wider for those with prior infection-induced immunity, again, similarly very high vaccine effectiveness, even with 2 doses of vaccine, and more so with hybrid immunity when it came to protecting against hospitalization and death due to the BA.2 sublineage. So now I want to just briefly share the experience in South Africa. And these data have been published, but I'm going to provide you some updated data as to what has been more recently experienced with BA.4, BA.5, and in fact the impact which Omicron had when it came to the number of people that were actually infected in South Africa. So fortuitously, what happened in South Africa, in Gauteng at least, is that we were completing a serious survey at a population level in Gauteng, which ended just before the onset of the Omicron wave. At the time of the onset of the Omicron wave in Gauteng, on the 25th of November, the number of individuals that had received at least a single dose of COVID-19 vaccine in the population was sitting at about 36%, and this is the target population of adults above the age of 12 years. 1/3 of them had received at least a single dose of vaccine. People above the age of 50, about 60% had also received at least a single dose of vaccine. But also notable here is that the number of adults above the age of 50 that had received at least 2 doses of either of the vaccines was in the region of only about 45%. Now, what the Sero survey showed, and again to emphasize that these are data prior to the onset of the Omicron wave, is that what had transpired in South Africa over the course of the first 3 waves is that overall in the population, 70% of individuals were seropositive. Now, when we stratify that further by those individuals that were vaccinated and unvaccinated, in unvaccinated individuals, and particularly in those above the age of 12 years, 70% of them were seropositive, indicating that 70% of unvaccinated individuals had developed some sort of immunity because of past infection during the course of the first 3 waves of COVID-19 in South Africa. Unsurprisingly, in vaccinated individuals, because of vaccines also inducing immune responses, the seropositivity rate was in the region of 90%. The seropositivity rate was a composite of either anti-nucleocapsid, nucleocapsid, or anti-spike protein IgG positivity. So the composite of the two is what we use to measure the seropositivity. So 70% of the population at least had been infected at least once since the start of the pandemic, even before the onset of the Omicron wave in Gauteng. The population of children under the age of 12, perhaps slightly lower, sitting at about 55% before the onset of the Omicron wave. Now, with that extensive immunity, what we were able to demonstrate in this particular analysis is that there was this massive decoupling of hospitalization as well as death when it came to the number of cases that transpired during the course of the Omicron wave compared to what had transpired earlier. What these figures basically are illustrating is that the percentage indicates the percentage contribution of that particular wave to the total number of hospitalizations, deaths, or whatever else it might be since the start of the pandemic, and the figure in parentheses indicates the incidence per 100,000. So if we just focus to the third and the fourth wave, which were due to the Delta variant and Omicron variant respectively, the Omicron variant wave contributed to only 10% of all of the COVID-19 hospitalizations in Gauteng since the start of the pandemic, compared to 44% of COVID-19 hospitalizations having transpired during the Delta variant wave. The Omicron variant wave contributed to less than 5% of all of the deaths from COVID-19 that transpired in Gauteng since the start of the pandemic, compared to 50% that transpired during the course of the Delta variant wave. As I mentioned, not all of this death in the Delta variant and not all of this hospitalization in the Delta variant could have been avoided had we used the AstraZeneca vaccine that was available to us in February, but we chose not to use it, and the consequences of that is that, unlike in the United Kingdom, where they already saw a decoupling of infections and severe disease and deaths with a Delta variant wave, because they had already vaccinated 70% of their population before the onset of the Delta variant wave, COVID-19 ran rampant in South Africa, having left our high-risk population completely unprotected with the vaccines that we did have at one stage. And these are data, again, it's very similar data. I'm not going to go into the detail, but pretty much emphasizing the same thing. And this is specifically for age group of 50 to 59, but very similar to the overall population, where the majority of cases and death transpired during the course of the Delta variant, whereas with the Omicron variant, we saw this decoupling of infections relative to the number of hospitalization and death. So where are we now? We are now faced with another resurgence, or at least the tail end of the fifth wave, which was largely driven by the BA4 and the BA5 sublineages. When the BA4 and BA5 sublineages were first identified, there was some concern in that it possibly was even more antibody evasive than BA1. And part of this was based on the study, which basically illustrated that individuals that had recovered from a BA1 infection, then utilizing antibody activity against BA4 as well as BA5 was lower compared to the utilizing antibody activity against BA1, and more so in unvaccinated compared to vaccinated individuals. So what this data basically suggested is that even recent infection with BA1 probably wasn't going to give you complete protection against BA4 and BA5 sublineage infections. And there was a concern that perhaps we might be even worse off than where we were with the BA1 sublineage, the BA1 variant of concern. So as luck would have it, we then followed up our pre-Omicron serosurvey with another serosurvey, which was conducted between the 1st of March 2022 and 11th of April 2022. And this was perfectly timed to coincide with the onset of the BA4, BA5 sublineage resurgence in Gauteng. And these surveys that I mentioned are usually done in the same households, involving multiple different clusters, 16,000 clusters across the whole of Gauteng, and is done across all age groups. So what did we find? And these are now unpublished data, which I'm going to be sharing with you. What did we find with the most recent survey? So this is a serosurvey that I alluded to before, which was a serosurvey undertaken prior to the onset of the Omicron wave. And this was a serosurvey after the onset, after the Omicron wave has subsided, but before the onset of the fifth wave due to the BA4, BA5 sublineage. And what we show in South Africa is that seropositivity had now increased from 76% to 92% across the population. Some variability across the different districts, 86% in Tshwane, 92% in Ekurhuleni, but overall at the population level, 92% of individuals across all age groups have got some level of immunity against SARS-CoV-2. Obviously, this is an overall seropositivity, including vaccinated as well as unvaccinated individuals. And as I'll show you, in fact, the seropositivity doesn't differ much between vaccinated and unvaccinated individuals. So before the onset of the Omicron wave, overall, and this is now specifically for unvaccinated individuals, and pre-Omicron and post-Omicron seropositivity at a population level before the onset of the Omicron wave, 68% were of unvaccinated individuals were seropositive. Post-Omicron, 90% of unvaccinated individuals are also seropositive. And this increase is evident across all age groups, including the less than 12-year age group, Before the onset of Omicron, we were sitting at about 55% seropositivity. That had now increased to 85% seropositivity. And across all of the adult age groups, greater than 90% of unvaccinated individuals who make up the majority of the population still do have immunity against SARS-CoV-2, and particularly immunity that protects against severe disease and death. So when we look at age group stratified analysis, and this is basically specific to the third wave, comparing unvaccinated to vaccinated individuals. As I mentioned, in unvaccinated individuals, 90% are seropositive. Unsurprisingly, a slightly higher number in the vaccinated individuals, sitting at 96%. Now, what does all this mean? What we also did in the study, and I don't expect you to understand the slide, it's really an introduction to the next slide, is that because we were going to the same households, we had paired samples. We had samples that we knew the serostatus of individuals that were sampled before the onset of the Omicron wave, and then we had samples of individuals that were sampled after the onset of the Omicron wave. And depending on whether they were vaccinated or not, looking at seroconversions as well as greater than a twofold increase in NTN or NTS, we were able to quantify the number of people that were infected just in that interval between the onset of the Omicron wave until the end of the Omicron wave. So this is the number of people that were infected during the course of the Omicron wave. So what I want to first speak to are individuals that tested seronegative, both for S as well as N, before the onset of the Omicron wave. And these are individuals which we can consider to have never been infected prior to the onset of the Omicron wave. In those individuals, 74% of them were infected with Omicron in that single fourth wave. 74% of people that had never been infected prior to the onset of the Omicron wave in South Africa and Gauteng were infected just during the course of that particular wave. Overall, if we're including people that were previously seropositive as well as the seroconversions, and now we're looking at overall evidence, serological evidence of infection at a population level, that's set at 61%. So 61% of people in Gauteng, 2 out of every 3, were infected with Omicron. Obviously, the majority of those infections were largely undiagnosed, as I'll show you in the next slide. But summary of it, if you hadn't been infected with SARS-CoV-2 before the onset of the Omicron wave, you are very likely to have been infected, and at a population level, 60% of the population were infected with Omicron BA1 during the course of the fourth wave. When looking at this in different age groups, and I'm just going to again focus the seroconversion are those individuals that were previously naive prior to the onset of the Omicron wave. As an example, in the 12 to 17-year age group, the numbers were few, but 87% of those few individuals that hadn't been previously infected were infected during the course of the Omicron wave. 74%, as I mentioned, across Gauteng. Overall, when we look at the rate of infection in different age groups, ranging from 56% in those older than 50 years, up to 73% in the 12 to 17-year age group. So 3 out of every 4 children in the 12 to 17-year age group were infected with Omicron during the course of the fourth wave. What we also showed, and this is somewhat surprising, is that infections, in fact, were less common in people that had received at least one COVID-19 vaccine, and even if that vaccine was prior to the onset of the Omicron wave. So in the 12 to 17-year age group, the serological evidence of infection during the course of the Omicron wave was sitting at 56% in those that were vaccinated compared to 77% in those that were unvaccinated. And similarly, you see these differences. In the greater than 50-year age group, 65% of unvaccinated were infected with Omicron compared with 50% of those that were vaccinated. And important to emphasize, this is serological evidence of infection. These are not individuals that we had a positive PCR. So where has that landed us? Where that has landed us is that the most recent resurgence with a BA4, BA5 variant, and I think this has been experienced throughout, is even less severe than what was observed with the Omicron wave. And what this data basically now shows, it shows the incidence per 100,000 and the percentage contribution of that particular wave to the total number of cases or hospitalization, recorded death, or mortality. So if we just look at mortality as an example, during the course of the first 3 COVID-19 waves, the mortality rate in Gauteng was, using excess mortality data, was sitting at 365 per 100,000. that mortality rate per 100,000 decreased to 19 per 100,000, only 5% of all deaths due to COVID-19 occurred during the course of the Omicron wave. And that figure, interestingly, remains similar with the BA4, BA5. However, the problem now is that the use of excess mortality is becoming less reliable to attribute causality to COVID-19. And what happened in the latest resurgence is that this resurgence took place at a time when both RSV as well as influenza was circulating in Gauteng. And some of these deaths possibly are related to other respiratory viruses which are now making a comeback as opposed to the earlier stages of the pandemic. And across all of the different parameters, as you can see, the majority of hospitalizations, the majority of cases documented, the majority of recorded deaths largely preceded the onset of the Omicron wave. And since the onset of the Omicron wave, the number of deaths, as an example, that occurred during the course of the BA4, BA5 dominant resurgence only contributes to 1% of all of the COVID-19 cases, deaths that have transpired, recorded deaths that have transpired since the start of the pandemic. So what this slide now tells us is of the number of inferred cases using the sero survey data, how many infections are required to result in one recorded case or one case of hospitalization or one case of death. So before the onset of Omicron, what we basically found is that for every 9 inferred cases using sero survey data, there were 9 recorded cases of COVID-19. With the Omicron wave, for every 35 cases of inferred infections using sero survey data, there was 1 recorded case. So we're seeing a greater difference now between the number of infections transpiring and the number of cases that are recorded. When you look at the number of people that are dying, for every 298 inferred infections that resulted, there was 1 death that was recorded before the onset of Omicron. Now what we're experiencing is that for every 5,500 infections that are inferred from the sero survey data during the course of the Omicron wave, there was 1 death. Using all of this data, the infection fatality risk, so this is the population where the number of people, the denominator is the number of people that are infected using the sero survey data, the infection fatality risk due to COVID-19 has decreased from 0.66% over the course of the first 3 waves to 0.03%, 20 times lower than what it was during the course of the Omicron wave compared with the first 3 waves. And this sort of experience in terms of changes when it comes to hospitalization with death is evident across all the different age groups. And I'm not going to go into the detail, just to emphasize that across all age groups, you're seeing the same sort of waning of magnitude of these waves, much substantially lower number of cases of hospitalization, death during the course of the 3rd wave, during the course of the Omicron dominant wave, as opposed to the earlier 3 waves, and even more so with the BA4, BA5 sublineage variant. So what next? And the short answer is that some of us pretend that we're still living in 2020, and the type of interventions the regulations that did probably very little, as I showed you from the data, to prevent infections are still regulations that are being held up. Pretending that the wearing of masks, especially when you're not wearing a mask that has a proper seal around the nose, around the mouth, the N95, KN95 mask, pretending that actually prevents infections when it simply doesn't, as the data shows, provides little value. Holding on to regulations that limits indoors gatherings as well as outdoor gatherings achieves very little. What it does achieve is expressed in this cartoon from Sabelo in June of 2020, almost 2 years ago. And that is, at that stage, COVID-19, the virus itself, was having a huge impact on the economy, on the livelihoods of people. Now it's no longer the virus that's having an impact on the livelihood of people. It's the government response, obsolete response to COVID-19 that is equally damaging to the economy and to the livelihood of people. And it's high time that South Africa does get a check with reality and realize that COVID-19 is not what it was 2 years ago, in a very different phase of the pandemic. So in summary, despite the modest vaccine coverage in South Africa, there's extensive underlying immunity that has evolved over time, even before the onset of the Omicron wave, and now even more so after the onset of the Omicron wave. As I mentioned, this immunity certainly is enhanced by vaccines because hybrid immunity does appear to be providing the highest level of protection, including against symptomatic disease as well as against severe disease, and particularly after the 3rd dose of vaccine. What we observed in South Africa and what we continue observing is a decoupling of infections and severe disease during the course of the Omicron dominant wave, as well as the more recent resurgence experience from the BA4 and BA5 sublineage variants, despite those sublineages and Omicron BA1 being antibody evasive to neutralizing antibody activity induced by past infection due to earlier variants, as well as neutralizing antibody induced by vaccines alone. We do expect further resurgences and variants to arise, but the chances of it being able to evade polyepitopic CD4, CD8 responses, and particularly when those responses are now a combination of not just vaccines, but vaccines as well as infections, the chances of such a variant evolving that is able to evade T-cell immune responses to the extent where it renders past infections and vaccines redundant in protecting against severe disease is extremely slim. If that does transpire, for all intents and purposes, it takes us to a new virus and it takes us back to March 2020. And pretending that we need to hold on to regulations in that unlikely eventuality that that would transpire, unfortunately, as I mentioned, does nothing more than continues inflicting damage on our economy, on the livelihoods of people. Is there still a space for things such as masks? And certainly there's still a space for masks, especially when there's a resurgence, and especially high-risk individuals, and more so if they're inadequately protected from vaccines. They should probably still take precautions to protect themselves from developing, from being infected with the virus. But those sort of precautions needs to be measured, and it needs to be precautions which basically are effective. It can't be asking them to use a cloth mask, which does very little, if anything, in protecting an individual from being infected. They would then need to use the right type of mask and use it correctly, especially when in indoor spaces. So where to next? Certainly what we need is better COVID-19 vaccines. We would love to have fewer cases of infection. We would love to have fewer cases of long COVID. We need better COVID-19 vaccines. We need vaccines that expand the repertoire of T-cell responses. There are vaccines that are currently under trial, including in South Africa, which looks at both S as well as N proteins as part of the same vaccine. We need to look at vaccines that are virus vaccines, as well as mucosal vaccines. And those vaccines will come to us, hopefully in the next year or so. But in the meantime, we need to learn to live with the virus. So I'd like to acknowledge a number of people. Obviously, much of the work that I've presented comes from VIDA, the Vaccines and Infectious Disease Analytics Research Unit, a number of staff that have been involved in different spheres of the research. And then a number of people from NICD that have also assisted in providing data, including the data that is shared with regard to the trends in relation to population seropositivity. So once again, thank you for the opportunity and hope you found this useful.
Thank you, Professor Madhi. I mean, I think that was a treat, and I'm sure that all of us would agree that, looking at the pandemic from when it started to where we are now, we're certainly in a very different phase. Thank you for that. I wondered if there are you able to take any questions? Because, I mean, it is exactly 2 o'clock. I'm not sure what the time.
I can take a few questions for the next 5 minutes and then we should be good.
Okay. Any questions from the floor? I'll just check quickly.
Hi, this is Tom. Sorry, I didn't put my hand up.
Yeah, that's okay, Tom. Go ahead.
Just a question, Shabir. In the study where you could look at Omicron infections in those who are either vaccinated or not vaccinated, how did you actually do that? How could you, in people who are already vaccinated, pick up Omicron infection? Was that based on N and basically antibodies to other genes, other than spike?
Yeah, so Tom, thanks for the question. So in fact, that was a slide that I rushed through. And basically we did different sort of analysis. The one analysis we did was basically looking at people that were vaccinated before Survey 2 and didn't receive any subsequent vaccine up to the time of Survey 3. And then we looked at, in those individuals, we looked at more than a 2-fold increase in either N or S. In individuals that received a vaccine in that interval period, we would only consider them to have had new infection, serological evidence of infection, if there was more than a 2-fold increase in anti-N IgG. So there is an algorithm that we've used to basically stratify based on whether individuals were vaccinated or not vaccinated, and of those that were vaccinated, whether they had any additional vaccine in that interval period between the two serious surveys. So hopefully we'll have a preprint out soon, and you'll be able to get more of the detail. But this, again, to emphasize, is serological evidence of infection. We did the same analysis looking at more than a 4-fold increase, and doesn't make much of a difference in terms of the conclusions.
So another question we have is Richard Naidu. Can you unmute yourself? And then we'll go to Sana.
Can you hear me?
Yes, we can hear you very well.
Thanks for a brilliant talk. That was excellent. I just wanted to ask, given the data that you've shown, is there any way of you or the group influencing the government to reduce or relook at the regulations that are currently in existence? Thanks.
Yeah, Richard, I wish I had that power. I mean, I've been singing from the same hymn sheet for the past 6-8 months. I think, like I said, where 90% of the population have got reasonable protection against severe disease, and where we're pretty much seeing a nominal amount of COVID-19 hospitalization and death, and pretending that people are actually adhering to these regulations when they're actually not, doesn't achieve much. And hopefully South Africa really, the government and the decision makers, really come to appreciate that they need to be driven by the science and do what all other countries are doing. It's not that South Africa will be an exception. In fact, we're playing catch up now to adopting what most other countries have already adopted, and that is doing away with regulations, but at the same time, doing what is required to continue increasing vaccine coverage and continue investigating for new vaccines.
Thank you very much. I guess everything is in line with what we look at that's happening in the UK and Europe, where you look at all these big soccer games, etc., and it just aligns with what you were saying and with your talk. Thank you.
Cool. We'll go to Sanel Ngobo. Go ahead.
Thanks for the opportunity. Prof, do we have an idea on how long the immunity lasts after being vaccinated, or to those who had COVID previously?
Yeah, so the antibody doesn't last too long. And even after a third or the fourth dose, you get waning of antibody fairly quickly. And as was shown in studies from Israel, in fact, protection against Omicron after fourth dose only lasted a few weeks. So the antibody doesn't last long. The big question is, how long does a T-cell immunity last if our main focus is around severe disease and death? And obviously with COVID-19, we now got data for just over a year, which largely shows that you do have persistence of T-cell responses for at least a year. But when you look at MERS coronavirus, which was around for a longer period of time, those T-cell responses were still evident 5-6 years after people have been infected. And I think at a general population level, there's very little reason to believe that those T-cell responses are not going to be resilient and last for at least 4 to 5 years. So no, we don't have the short answer, but the other dimension to this, unlike MERS coronavirus, which was almost a once-off infection, what we experienced, as I showed you from the data in South Africa, is we got repeat exposures now. And those repeat exposures, if anything, is going to enhance your T-cell responses. So we don't have I think when we talk of durability of responses, it's very dynamic because there's ongoing exposures taking place, and that is always going to continue boosting both the antibody responses as well as the T-cell responses.
Very good. So I think maybe one short one. One is saying, are the vaccine mandates still necessary given these levels of immunity in South Africa? I think we have a couple of more, but maybe we'll stop there.
I'm sorry, I didn't get that question.
So the question is, are vaccine mandates still necessary given the levels of immunity?
Well, it depends what you're trying to achieve. Like I said, there's no question that hybrid immunity works better than vaccine-only induced immunity and probably better than infection-only induced immunity. You get much more robust antibody responses, neutralizing antibody responses from hybrid immunity, and I showed you the data for that. And when we talk of hybrid immunity in the context of neutralizing antibody, that is, when we talk of mandatory vaccine, the main purpose there is to reduce the likelihood of someone transmitting the virus if they are infected. So in that context, there still possibly is a role for mandatory vaccination, but again, not the same type of, I wouldn't put as much emphasis on it right now than I did a year ago. I think we now just need to learn to live with the virus. We've got extensive protection against severe disease. Unfortunately, there might be outbreaks taking place in closed environments when people are not don't have adequate immunity, but that is again something that needs to be decided on at the facility level. For universities, I still think, and Wits has still got a mandated vaccination policy. I think up until now, it has served us well. Whether we should, we've got 95% of our of what staff and students have been vaccinated. So we can do away with our mandatory vaccination policy because the mission has been accomplished. And we got, in fact, what is probably one of the safest places to be in South Africa if you're going indoors right now.
Right. So maybe it's just that time window. Maybe some would missed it or something. I don't know. Very good. I think there was another question. I mean, if you can take one more.
Yeah, I'll take that question quickly. So the question was whether those individuals that were NTN and NTS seronegative were really SARS-CoV-2 naive. And that's a fair point. They weren't necessarily SARS-CoV-2 naive. And I think that's a caveat of that analysis in that they might have been previously infected, but we've used it in a different context, in that we were looking at a force of infection, but not all of those seroconversions, which I indicated are seroconversions. Some of them might have been in people, as you've mentioned, where antibody might have waned, and they were not truly uninfected. But the principle still holds in that they were NTN, NTS seronegative, and in that group, the sort of change in terms of seropositivity was much greater than in individuals that had that were either NTN or NTS seropositive before the onset of the third serosurvey, the third serosurvey. Yeah.
Cool. I think on behalf of the SAIS executive, thank you very much for this talk, and thank you for, I mean, giving us an update really on what has been going on and what is going on and what is about to go on. I think we are grateful for that, and we're also grateful for Tech for supporting us, and also Sanofi for supporting this webinar. Thank you all for coming, and thank you, Professor Madhi. Much appreciated. Cool.